Okay, so good evening. Now, in this presentation, I'm going to talk much about G6PD deficiency. It has become one of the important topics nowadays, and we need to talk about this. And throughout this presentation, we are going to look at introduction, basically the general overview. When we talk about G6PD, what is it? Then we add the pathophysiology of it. We also talk about the mode of inheritance. Since it is a genetic disorder, we have to know the mode of inheritance. And of course, we look at the clinical presentation. Then we talk about GSPD in pregnancy, very important. There are some agents that we have to avoid in GSPD conditions. We will talk about that. And of course, we also talk about laboratory diagnosis of G6PD deficiency. Then we look at prevention and if possible, we talk about the treatment. So the introduction. First, let's talk about the functions of G6PD. Remember, G6PD stands for glucose phosphate dehydrogenase. And so it is a metabolic enzyme which is involved in the pentose phosphate pathway, especially important in red blood cell metabolism. You know, red blood cell is one of the important cells, in the body. It is one of the important cells that helps transport oxygen to all parts of the body. Once you have defect in red blood cells, which normally happens in this PD deficiency, you see there is tissue hypoxia, and then sometimes there is intravascular hemolysis, which will lead to decreased hemoglobin level. And so this topic basically focuses on G6PD enzyme. What is it? What is its role? Why is it very important to know? And so we're saying that G6PD is a metabolic enzyme which is involved in the pentose phosphate pathway, especially important in red blood cell metabolism. The pentose phosphate pathway is one important pathway that the red blood cell uses to ensure its integrity. So for now, what I want you to put in mind is that glucose phosphate dehydrogenase is a metabolic enzyme which is involved in the pentose phosphate pathway. And I said I am going to elaborate more on the pentose phosphate pathway. Now, in the body, we have certain harmful substances or molecules which are called reactive oxygen species. You know, these reactive oxygen species affect the red blood cells. What they do is that when they get access to the red blood cell, they tackle it, denature it, and releases the hemoglobin out, which leads to hemolysis, breakdown of the red blood cell, release of hemoglobin. So these reactive oxygen species are very harmful. They do not have to get access to the red blood cells. And so it is the function of the G6PD enzyme to protect the red blood cell against these reactive oxygen species. One common example we talk about is the peroxide. We have the O2 minus there. We have the hypochlorite. All these are reactive oxygen species that can denature the red blood cell. Glucose phosphate dehydrogenase enzyme is basically a housekeeping enzyme for all red cells, and it is important for the integrity and function of the red blood cells. So the question now is, how does G6PD enzyme help protect the red blood cell against these harmful molecules we call the reactive oxygen species? But our interest for today is the glucose going through the pentose phosphate pathway to give us 5 ribose phosphates. Let me explain it again. You see, this is glucose. And this is the G6PD enzyme. Now, this G6PD, what it does is that on the pentose phosphate pathway, glucose is converted to 5 ribose phosphates. But before the conversion can occur, there's a molecule that we call NADP, adenine dinucleotide, NADP. The NADP, when it is in the circulation, it is inactive. Okay, so it is the function of this enzyme called G6PD to activate it. And so this G6PD enzyme will activate NADP to NADPH. So the bottom line is, in the presence of G6PD enzyme, NADP will be activated to NADPH. And what will NADPH do? There is a molecule we call glutathione. Glutathione is very important molecules when it comes to the protection of RBCs against oxidant species. But the funny thing is that glutathione is inactive when it is in circulation. So it also needs something to activate it before it can perform its function. And so it is the function of this NADPH to activate glutathione. So NADPH activates glutathione into its reduced form. And the function of glutathione is to protect the RBCs from the oxidant species, the peroxide, the hypochlorite, and the rest. How does it do that? It does that by either converting the harmful molecule called peroxide into water, which is okay for the body. And so what I want us to take from this diagram is that in the presence of G6PD, NADP will be reduced to NADPH. And once we have NADPH, it is also going to reduce glutathione to its reduced form. And once glutathione is activated, it can now, reduce the oxidant stress caused by the oxidant species. So what it means is that in the absence of G6PD enzyme, all these processes will not occur. Glutathione will not be reduced, and therefore the oxidant species will get access to keep on denaturing our red blood cells. So you see how important G6PD is. Reduce nicotinamide adenine dinucleotide phosphates. In today's, which will also lead to generation of this glutathione. So once we don't have glutathione, it makes our red cells susceptible to oxidant stress, and then it leads to damage. There's removal of hemoglobin into hens bodies, which is therefore removed from circulation, which we call intravascular hemolysis. And so it is very important. Now, G6PD deficiency, this disease was discovered in the 1950s after it was observed that some black soldiers receiving anti-malaria drug primaquine develop hemolytic anemia. Of course, today as I speak, it is the most common red cell enzymopathy associated with hemolysis. Yes, and so G6PD deficiency is the most common red blood cell enzymopathy or enzyme diseases that is associated with hemolysis. Of course, when you lack G6PD enzyme, because it cannot generate glutathione, always the hemoglobin and red cell membranes are usually protected from oxidant stress by reduced glutathione. But in G6PD deficiency, both NADPH and glutathione synthesis is impaired. Once it is impaired, the red cell is always ready to accept oxidant stress, which will lead to hemolysis. So the pathophysiology, how the disease occur. There is oxidative denaturation of hemolysis because the red cell is always exposed to oxidant stress. Okay, and so the lack of the enzyme leads to insufficient or lack of production of glutathione, and of course always the red cell is exposed to hemolysis. And then normal red cell have sufficient G6PD activity to maintain adequate glutathione levels. Okay, so once there is deficiency, red blood cell fails to produce sufficient G6PD, and peroxide and other oxidant species cannot be detoxified, and therefore hemoglobin is then oxidized to methemoglobin. Once it is oxidized to methemoglobin, hem is reduced or liberated from globin, and globin denatures, producing Hen's bodies. Of course, Hen's bodies attach to the membrane of the sulfonyl groups, which induce cell rigidity and causes hemolysis, which is very important. So this is a pictorial view of what I have discussed. Okay, this is glycolysis, pentose phosphate pathway. In the presence of this PD enzyme, it generates reduced nicotinamide adenine dinucleotide phosphate, which also generates reduced glutathione. When there's glutathione, harmful peroxide will be converted to water, and it is okay for the body. But once the body do not get the G6PD enzyme, all this will not occur. And this harmful peroxide, the other reactive oxygen species, always kills or denatures the red blood cell. It's as simple as that. So this is a normal red cell under the microscope. When there's G6PD deficiency, this is how they look. Hence bodies. Hence bodies. Okay, very important. According to WHO, as I speak, about 7.5% of the world population are carriers of G6PD. Out of the 7.5%, 2.9% are G6PD deficient. And so I don't know, if you don't know your status, you have to start checking. Maybe you may be part of the 2.9%. Who knows? And once you are part of them, you have to know how to take your medication. Then G6PD basically is a genetic disorder, okay? So it is a deficiency which occurs on the X-linked gene. So glucose phosphate dehydrogenase is an X-linked genetic disorder which is caused by mutations in the G6PD gene on the telomeric region of the long arm of X chromosome. Okay, so basically it is mutation. You know, G6PD is an enzyme which is a protein. Here the disease occur on the S-linked S gene. Okay, where there's mutation in the G6PD gene. So the gene that are involved in the formation of the G6PD enzyme are mutated, and the mutation results in protein variants with different levels of enzyme activity that are associated with a wide range of biochemical and clinical phenotypes. Okay, very important. Mutation is one of the things that is causing, different genetic effects in most patients. So most of the genetic disorders are due to mutations. Okay, so the enzyme activity may reduce and leads to different biochemical findings that we talk about. Of course, G6PD, the mutation of the S-linked gene, about more than 200 mutations are identified as I speak and are recognized as a cause of G6PD deficiency, and it affects over 400 million people worldwide. This condition is S-linked recessive. When you study pedigree or genetics, when you hear S-linked recessive, meaning that affected sons get it from their affected mother. Okay, anytime it is S-linked dominant, meaning that affected daughters also get it from affected fathers. And so basically, this is S-linked recessive. So men are always affected. But we only have one of the X chromosome, which is called hemizygous, And so the expression is either we have it or we don't have it. So it's either deficient or normal. In contrast to this, females also have two copies of the gene, and therefore the gene expression can be normal or heterozygous. So it may be there, but the conditions may not show as it is. So this is the chromosome. So you can see there's a long arm of the chromosome. Position number 28, that is where the mutation occurs. So this is a pictorial view of how the disease is being inherited. Female can be carriers, but male either you are affected or it is normal. This is a pedigree showing how the disease affects both gender. Let's talk about the clinical presentation of G6PD deficiency. Most patients are asymptomatic unless exposed to something that will trigger hemolytic episode. One funny thing about G6PD is that when you have it, you don't normally show symptoms, okay? But we have certain drugs and certain chemicals, even food substances, that may trigger hemolytic episode. So somebody can be G6PD deficient, but the person will be walking as if nothing has happened to him or her. But once you are exposed to something that will trigger hemolytic episode, remember I told you that these reactive oxygen species are those that causes hemolysis, okay? And so if you are G6PD deficiency, there are certain drugs and food substances, even certain infections, diseases, condition that also trigger hemolysis when you are exposed to. Some of them are oxidative drugs, which include the anti-malaria medications that we normally use. I'll talk about them. Infections, certain infections can also trigger hemolysis, and then fava beans. These three things are the main triggers of hemolysis. So if you are G6PD deficient, you should be very careful. And then once you're exposed to these things, it may lead to transient hemolytic episode within several hours of exposure and may begin the return to normal once the offending trigger is removed or resolved. Normally, hemoglobinuria may be one of the first clinical clues, okay? So hemoglobin in urine, then we suggest that, okay, let's do G6PD test. But once there's hemolysis, there's breakdown of hemoglobin, okay, and we can determine that in urine as well. Then individuals with G6PD deficiency could present with a spectrum of disorders, which include arteriosclerosis. Okay, arteriosclerosis is basically one of the disease that is caused by, excess cholesterol in the body. Okay, where the arteries that carries blood to the heart may block. In G6PD deficiency, if you are not lucky, you may also present with arteriosclerosis, which is very harmful to the body. Okay. Then cardiovascular disease. Always when there is hemolysis, your hemoglobin level may be low, so there's poor perfusion to the heart. And as time goes on, if it continues like that, there may be poor perfusion. I know the heart may stop working, and it leads to cardiovascular disease. Of course, one common thing that we normally see in babies is neonatal jaundice. When a woman who is G6PD deficient is pregnant, the likelihood that she will give birth to a baby boy who is G6PD deficient is about 99%. And therefore, once there is, G6PD in neonates, it always presents as jaundice. Okay. Then, of course, G6PD also leads to acute massive hemolysis. Okay. Renal failure, kidney failure, one of the common things that is associated with G6PD deficiency because of poor perfusion to the kidneys. And of course, if you don't take care, it can lead to chronic hemolytic anemia. There are some agents that may cause hemolytic anemia in glucosase phosphate dehydrogenase. Some of the agents are infections. One common infection that we talk about is diabetic ketoacidosis. DKA is the hallmark of type 1 diabetes, where there is increased level of glucose and ketones. Of course, it can be acetoacetate, hydroxybutyrate, all those ketones in urine. The etiology is not all that known how diabetic ketoacidosis, I mean, affect G6PD deficiency patient. One infections is hepatitis, hepatitis A and B. Okay, when you are G6PD deficient and you also get hepatitis A or B, it may increase your risk of hemolysis, may hemolyze the red cell, okay? And so people with G6PD deficiency are to protect themselves against hepatitis A and B. Typhoid can cause hemolysis, pneumonia, cytomegalovirus, just to mention few, very important. And then the drug aspect. This is where my interest is, because most of the people we deal with, our patients there, are naive, and therefore when they go to places to buy drugs, when you give it to them, they just take it anyhow. Some of them don't even know their G6PD level or their G6PD status. So they take in drugs, develop reactions, hemolytic episodes, complaints day in, day out. So it is our work as clinicians or medical officers to advise the public to always come and check their G6PD deficiency. And to most medical directors, every patient that is being given these drugs should be allowed to check the G6PD level, because these anti-malaria drugs, primaquine, pamaquine, chloroquine, fasida, morphine, all these drugs leads to hemolysis when the patient is G6PD deficient. Sulfonamides and sulfones, example, cotramazole, sulfanilamide, dapsone, and sulfasalazine, all these drugs trigger hemolysis. So if you are G6PD deficient, you are not advised to take this. Other antibacterial drugs like nitrofurans, chloramphenicol, all these drugs trigger hemolysis. Analgesics, aspirin, antihistamines, all these can lead to G6PD or trigger hemolysis in G6PD deficiency. Miscellaneous, vitamin K, analogs, naphthalene, all these can cause hemolysis. And so if you are G6PD deficient, it is never advisable to take in any of these drugs. Fava beans, which is well known to trigger hemolysis, G6PD deficiency. Don't even venture. Fava beans, don't venture if you're G6PD deficient. Soy, peanut, legume, all these can also cause, but the most important one is the fava beans, okay? So this is the fava beans I'm talking about, okay? If you're G6PD deficient, don't go there, because it is one of the common food substances that trigger hemolytic episodes in G6PD deficiency. And then one thing that people have been asking, why is it important to perform G6PD test for pregnant women? So the first one is to monitor intermittent preventive treatment. You know, in Ghana here, okay, pregnant women are entitled to anti-malaria medication. The common ones that they give them is a sulfadozine and pyrimethamine tablet, just to prevent malaria in cases, of pregnancy. So if you're G6PD deficient pregnant woman, if you're G6PD deficient pregnant woman, it is never advisable to take sulfadozine and pyrimethamine tablet, because these drugs can cause hemolysis. That is why every day, or it is part of the routine for all pregnant women to come to the lab to check for G6PD level before they are being given these drugs. Another one is hemorrhagic disease of the newborn. You know, when neonates or babies are born, they don't have matured liver, and so there are some factors, okay, clotting factors that depend on vitamin K for their production. Example is factor 2 dependent on vitamin K. But the newborns, because their liver is not matured, they can't produce vitamin K, let alone producing the clotting factors. So because they can't clot the blood, always there is hemolysis. That's what we call hemorrhagic disease of the newborn. So you give birth to the newborns and there is always hemolysis. Sometimes doctors want to prevent this. So the best thing they can do is to give them intramuscular injection of vitamin K. Now we said that vitamin K also trigger hemolysis. And so it is very important to perform this G6PD for a woman or a pregnant woman, because we know that pregnant women, if you are G6PD deficient female, you are likely to give birth to a baby boy who is also G6PD. So imagine you have given birth to a baby boy who is G6PD deficient, and we are also giving him vitamin K intramuscular injection. You can imagine continuous hemolysis, maybe you will even die. These are all part of the reasons why doctors always request for G6PD test to be done before they know how to administer certain drugs like this. The third one talk about is that G6PD deficiency in pregnancy may manifest as increased urinary tract infections, preeclampsia, neonatal jaundice, heart drops, fetalis, and stillbirth. G6PD, because once there's G6PD deficiency, all these symptoms will be shown. And the last one, to reduce the risk of anemia in fetal or maternal death. Of course, that is the main aim that we do that. Okay. And so let's go to the laboratory. So the laboratory testing. Anytime GSPD patient come to the lab, when you run full blood count, normally it is normal. Okay, unless you are exposed to something that will trigger hemolysis. But if you are not exposed to something that will trigger hemolysis, always your full blood count results is normal. But once there's hemolytic episodes, once there is hemolysis, once there's breakdown of the red cell, maybe you have been exposed to some drugs that are causing hemolysis, then there will be what we call the nomocytic or nomochromic anemia. And your hemoglobin level may drop quickly. Of course, response can be variable, but then hemoglobin level may drop because there is hemolysis. Okay, some people even present with hemoglobin level less than 4, some come with 3, some come with 6, and it's very bad. Yes, in the lab we also still see bite and blaster cells when we use the rastin. Sometimes we see hens bodies, of course, not sometimes, normally see hens body and other morphologic findings. Okay, glucose phosphate dehydrogenase enzyme activity screens. These are the tests that we use to determine the presence of the enzyme. Sometimes we rely on them to assess the degree of the severity of the disease. One common test that we do is the methemoglobin reduction test, and we run our test. In this test, we use EDTA anticoagulated venous blood, which is very important. We do not want to use, hemolytic blood. So the blood should not be collected during. Then the test should not be performed soon after transfusion. Okay, don't transfuse the patient before you come around the test, because the transfused red cells have the enzyme. So the patient may be negative, but it may be a lie, because the red cells are transfused ones, which do not represent that of the patient. Okay, and of course, this is one of the defect patient. See the color of the test and the color of the positive. This is the normal, so full defect. Okay, how do we prevent this G6PD? The most important measures is prevention. That's it. G6PD, basically, when you get it, you can treat it, but you have to prevent it. How do we prevent that? By avoiding the drugs and the food that cause hemolysis. Okay, and you must be vigilant. That is why everybody must know their status, because you may not know the drug you'll be using the next day. Came out that he went to a hospital where he was given certain drugs. He took them for about 8 months and realized that it contains some sulfur drugs. He also know where that he's G6PD deficient back in school. And so he went to the doctor asking why they gave them the drug. The only thing they can say is they are sorry. Later he developed kidney disease and there is no more. So you see, it's very important to be vigilant when it comes to G6PD deficiency. I already said that hepatitis A and B, if you are G6PD deficient and you are not lucky and you get this, the hemolysis will be severe. Always your hemoglobin will drop. And therefore, whether you are G6PD deficient or not, the best thing is to vaccinate against hepatitis B and A. Okay, so that is that. Well, when hemoglobin level drop, the only thing we can do is to do transfusion, because the transfused red cells are generally not G6PD deficient. And it will, live with you for some time before they are taken out of circulation. Whether acute phase of hemolysis, you can either rely on dialysis in acute renal failure. So that is the end. Thank you very much for joining. Subscribe for more videos.